I'm Amy Fisher. I'm a practicing obstetrician gynecologist here in Eagan and in St. Paul. I'm a parishioner here at St. John Newman. I'm here with Anna today, and we're going to talk about some of the major stumbling blocks and some of the common questions and concerns couples have as they approach the idea of putting natural family planning into play in their marriage. Just a quick background on my own history. I actually grew up in the Evangelical Free Church here in the Twin Cities, went to medical school, went to residency with the plan to become an OBGYN. And it was after I completed my OBGYN residency that I came into the Catholic Church. And at that point, the priest turned to me, and I recall very clearly that he just basically said, "You're going to have to figure out what to do." And I kind of laughed and I thought, well, yeah, I do. And since we were trying to achieve pregnancy at that point, I'd finished all my training. It was very easy to start practicing natural family planning in our own married lives. It did take many years for me to relearn how I think about women's health so that I would be able to practice fully in line with what the church teaches about the dignity of a woman's body and the beauty of sex. So currently I am practicing a fertility awareness-based practice here in Eagan and St. Paul. And I have practiced for many years using standard gynecology, standard obstetric medicine, and to that I've been able to add quite a bit of restorative reproductive medicine and how to apply those techniques to help women and couples live their marriage fully.
First of all, thank you so much, Dr. Fisher, for being here with us today. It is so important to address those common questions and stumbling blocks within NFP as couples go about discerning it within their marriage. It's wonderful to have you here to really address those questions that you've received in your own practice. So thank you. The first question that often comes up is, how is NFP different than contraception?
So natural family planning is totally different than using contraception, whether you're using it in a marriage. You can actually use natural family planning as a woman who's single, who's not sexually active, as a way to monitor ovulation for health. Another term that couples use is fertility awareness methods. But when we talk about natural family planning, we're talking about a couple who is working with the physiology of their fertility, so both the male and the female fertility, to track when ovulation is happening. And so they're aware of how they were created, they're working with the way they were created. Whether or not they're choosing to have sexual intercourse in the window of time where pregnancy can happen is a choice that they're able to make from month to month. Always aware that even at their best ability to track those biomarkers, that sometimes there will be an error in their own note-taking that may lead them to achieve a pregnancy. And their awareness of this is a recognition that this is how we were created and that God can work no matter what we have in store. Whatever our plan is, He may have something different. And so it's always an openness to life when you are using natural family planning, because you've already made that decision that God is part of that decision-making process, and that ultimately He may override what, as a couple, you discern would be the right path to take. Now, when you're using contraception, you're actually using some form of birth control, whether it's a barrier method or whether you're using a hormone suppression, using an implanted device to say, I'm going to override this natural fertility that I have so that I don't get pregnant. And it can be one side of the couple using that method. So a woman could actually use that on her own without her husband's awareness. It could be both sides of the couple making that decision to do that, and yet they are always leaving God out of that equation. And the reality in that situation is that God's not out of the equation. And so that's where the true difficulty comes in with birth control, because as women, we really believe that's going to work. We've been told since the 1970s that this is going to be the way that we can achieve what we want to achieve in our lives with education and with our careers. And when it doesn't work, it's devastating. And yet there is absolutely no birth control that's 100% effective. Even a sterilization procedure, a tubal ligation, or a vasectomy is not 100% efficacious in avoiding pregnancy, because God can work. So the more honest way of looking at our fertility is actually to take into account what we were created for and who we were created for.
Another question that regularly comes up is, how can women practice NFP if they have been prescribed birth control to help manage different medical conditions?
That's a wonderful question. As an OBGYN, I've spent my career seeing women of all ages, so from the ages of 14 to 50, who have been prescribed birth control to manage all kinds of medical conditions. So from something that can be as scarring and difficult in adolescence as really bad acne that may persist into the 20s or 30s, to painful periods or heavy periods, or the combination of the two that keep girls away from school when things are really bad, or women who sometimes have to stay home from work because it's so severe. Perhaps this is the only way that they've been able to find any respite from the gynecologic conditions they're dealing with. So how in the world can they look at being open to the use of natural family planning in their marriage? I would answer that first by saying we have in our medical system today a lack of understanding of women's physiology. In the early 2000s, when I started my residency training, everything that we did was aimed at figuring out how to apply hormones to treat these medical concerns. There was a huge burgeoning in birth control pills. The Mirena IUD was just set to come out on the market as another form of hormone treatment that could help with gynecologic concerns. There was a Depo-Provera injection that was being used. And from 2000 onward, in the course of my career, that's only blossomed even further in multiple different ways. Many of these hormonal methods will actually override and suppress a woman's ability to ovulate. There are multiple medical conditions that can impact ovulation. So if we're not looking for why these bad gynecologic diseases are happening, we may not be actually treating the underlying problem. We can make the symptoms better by making the period go away. We can make premenstrual syndrome feel better by not cycling hormones at all, by just giving you a really low dose, steady state of hormone. But what we deprive women of by doing that over 10, 20, 30 years of their reproductive life is not having the appropriate amount of estrogen or progesterone that we were created to have. Why is that important? So getting back to that young woman who's 18 years old and can't go to school because her period's so heavy, somebody put her on birth control so she could get to school. There's nothing wrong with the intention of wanting to help somebody. And if doctors haven't been taught about ovulation and how to restore ovulation, if the healthcare system hasn't been aimed at that, then many of us have been put on those contraceptives, on those hormone suppressing means and mechanisms as a way to try to deal with our gynecologic disorders. The fact of the matter is, though, at the same time that the pharmaceutical industry was pressing onward, making all of these forms of hormone suppression, the oftentimes Catholic universities in this country were pushing forward with more research and knowledge regarding a woman's physiology and how to apply that to natural family planning. Again, if we go back to Humanae Vitae in 1960s, Pope St. Paul VI knew about this research that was coming and asked for more. And that's what our Catholic universities have done, and actually around the world there's been this resurgence of interest in restorative reproductive medicine, understanding what it takes to ovulate well. And so for these women who want to come off of hormonal contraceptive and they're afraid of what's going to happen, it is helpful in learning a natural family planning technique with your teacher to actually recognize where you can find a medical provider that can support you in that process. But having a history of being put on birth control for a medical problem never concerns me when a patient comes in about her ability to move forward with natural family planning, and for her to feel like she and her husband are able to successfully use that method and discern to avoid pregnancy or to achieve when they want to.
If NFP is new to a couple, it can feel so overwhelming to know where to get started. Can you speak to that?
Yeah, I feel pretty strongly about this one, actually. I have a lot of patients who come to me, and especially if they've been trying to fix something on their own, it is overwhelming in our day and age, the amount of information we can glean off of the internet on our own. And to figure out what are reputable resources, and then to try to collate that into some way that we're going to put that into play in our own lives can feel like too much. No one should have to do this alone. You know, God is a Trinity, He's a relationship, He made us for relationship, and natural family planning is about the relationship of the couple, and it's about the relationship of the body of Christ, even for that single woman who's charting on her own, or the teenage girl who's learning her body. She's learning it with her mom. So quite honestly, always check the resources with the Archdiocese for natural family planning teachers in the area. They can give you multiple different methods of natural family planning that you can start to explore. There is a website that has been up and running for several years that can be really helpful. It's called managingyourfertility.com. It was actually a website that was created to help couples go to one place and see different methods side by side, and what's involved in learning the method, what's involved in using the method, so that they could determine based on where they were in their life at that moment which method might be best for them. Beyond that, certainly buying books, reading blogs can be helpful, but I do think that it's helpful, especially with a history of needing some medical help for gynecologic problems. You want to have a healthcare provider who's really aware of what you are doing with your natural family planning, and who can use the information that you are finding in your charting to look for the root cause and to restore your health. So the code words we're really looking for are restorative reproductive medicine. We're looking for NAPRO technology. Creighton model charting was designed to support NAPRO technology. So if you are assuming that you will use NAPRO technology to treat your medical problems, you really want to find a Creighton model teacher. If you are using a different form of natural family planning, because it suits your lifestyle better, or your best friend's a Marquette teacher, that's okay. There are Marquette medical protocols. The FEM medical management protocols are probably the easiest medical management protocols that can be applied to any form of natural family planning without needing to chart within the billing system. And so FEM stands for Fertility Education and Medical Management. So you either want at this point to be looking for a FEM provider as well as a FEM teacher, or a FEM provider and your Marquette teacher, your billings teacher, your Family of the Americas teacher, or you want to find a NAPRO provider and a Creighton model teacher.
I know some women are told when they have a specific condition like endometriosis that for their disease they must control it with birth control. Can you tell us more about that?
Yes. For many years, since I was in medical school, and even before that, endometriosis has been a disease that's really destructive to both a woman's quality of life, destructive to her fertility, and really difficult to treat. So with the advent of hormone suppression, women were finally able to get some relief from the pain. As the techniques of laparoscopy for surgery as a minimally invasive surgical management of endometriosis has evolved, we have still stayed with the idea that hormone suppression should be the mainstay of endometriosis treatment, where in gynecologic surgery circles, the evolving way of managing endometriosis is excision of that disease. So we have a setup in this country where many women have been on birth control pills or Depo-Provera or using some form of hormone suppression for many years to control endometriosis. To try to avoid surgery, you have many medically trained physicians who are not surgeons who have been trained to put women on multiple forms of hormone suppression before referring them on for surgery. And yet we have the surgical techniques that have finally come to a place where that's becoming the mainstay of treatment in gynecologic surgery to excise the endometriosis. Well, why in the world would we want to cut out the endometriosis? Nobody wants surgery, but if we treat a young woman who is perhaps 20 or 22 years old for her severe painful periods, and we excise the endometriosis, we pull the lining surfaces back together to reduce adhesions or scar tissue that's created. We are removing the inflammatory response that occurs in the pelvis every month. We are removing the inflammatory response that can create more scar tissue over time. Hormone suppression doesn't do that. The endometriosis that you see in a 20-year-old woman who's having surgery is very early stage in appearance. When you wait and you do that surgery at 28 or 35, even if she's been on birth control pills all of those years, or even more strong hormone suppression, she has deeper, more involved disease than if we had done the surgery 15 years earlier. And what happens with deeply infiltrating endometriosis is we've lost some of the egg reserve in the ovary, we've created more scar tissue in the pelvis, we have started to get endometriosis growing down into the ureters, into the bladder, into the bowel, through the vagina and into the bowel. So we get this massively destructive disease if we wait. And while hormone suppression might be the key to buying some comfort and the ability to go to school or work right now, the real treatment is the excision of the endometriosis, because endo doesn't grow wide, it grows deep. So if we can get it before it grows deeply, we're more likely to restore and maintain fertility for the long run. So one of the mainstays in restorative reproductive medicine is to look at a surgical treatment for endometriosis. Does that mean that surgery has the only option, or that it has to be the first thing that a woman jumps into? Absolutely not. We're talking about a system of medical practice that has been proven in the medical research to show that it takes 10 years for a woman to get a diagnosis of endometriosis by surgery. In that window of time, her birth control pill has been changed at least 3 times, because that has been the standard of care, to recommend that the pill or the hormone suppression keep changing before we put somebody to surgery. By the time that 10 years has passed, that young woman is now 26 or 28, 30, and she is now coming off her pill because she wants to get pregnant. But that endo that's been there all along has grown deeper and has caused more scarring, and we're dealing with more infertility. So to take a year or 2 years to figure things out, to keep things comfortable, there are ways without using hormone suppression to do that. In fact, there are medications that can be used that have been proven now to shrink the endometriomas, to reduce the endometriosis implants in the pelvis without taking hormone suppression, all coming out in the literature in the last 2 to 4 years. So there are ways of treating without hormone suppression.
Very interesting. In a similar vein, some women are told that their PCOS can only be managed with birth control. What do you think about this?
It doesn't faze me at all. That also has a standard medical approach. Even our endocrinologists treat PCOS, or polycystic ovary syndrome, as if it is only one type. Now we know that there's 4 different subtypes of PCOS. And so PCOS is almost a garbage can diagnosis, where in standard medicine today, we are taught to lower the male hormone levels to help with acne, hair growth. And the way to do that, if a woman doesn't want to get pregnant, is to put her on a combined estrogen and progesterone birth control pill. That combination of estrogen and progesterone, again, is going to block out any functioning of her ovary and therefore decrease the male hormone levels. In addition, spironolactone is another medication that can be used to treat the high male hormone levels for acne and hair growth. They're also told that they need to work on diet and weight loss. So most women with PCOS, whether they have more weight on their bodies than they want or they don't, will be told at some visit, if not every visit, that they need to work better on a healthy diet and how much exercise are you getting. The major frustration for many of these women is actually that they're doing all those things and the weight isn't coming off, or they actually have a healthy BMI. They're not in a place where they need to be doing anything different. And so that's where those various subtypes of PCOS come in. If we're not treating every woman with polycystic ovary syndrome as if they're the same woman, we can start to search for what is triggering that high male hormone level. For some women, they have insulin resistance. In fact, that insulin resistance can show up with the onset of their first period at the age of 9, and they have very heavy periods from the very beginning. If these young women are placed on combined oral birth control pills, some of them, because of their insulin resistance they're already struggling with, will be sensitive to the fact that that birth control pill can increase their insulin resistance. And that can cause a weight gain that occurs. So as long as she's on that pill, it's worsening her insulin resistance, and therefore she can't lose weight and she becomes obese. So again, applying the same construct to every woman is not necessarily treating the underlying disease. And so I don't have any fear for a woman with PCOS. We just try to figure out what is going on. We sometimes don't even use that term PCOS. We use the term for what's driving the polycystic ovary change. And then with that, we're able to restore regular periods and regular cycles.
Thank you for sharing that. What if a couple is struggling to achieve pregnancy? Is there a difference in the way you would manage their infertility?
There's absolutely a difference. So again, if we go back, I was trained in conventional gynecology. I was trained to use Clomid to help a woman ovulate, even if we didn't know why she wasn't getting pregnant. So the usual management for a woman who came in, if it hadn't been a year of trying for pregnancy or no birth control, we would tell that woman or that couple, you need to wait for a year. At 1 year, we can institute infertility management protocols. And at that point, we're checking hormone levels from the brain, we're checking estrogen levels to see, are the eggs healthy? Are there enough eggs? We're checking a tubal dye study to make sure that the fallopian tubes are open. We are going ahead and maybe doing an ultrasound based on the woman's clinical history. We're doing a semen analysis because about 40% of the time there's male factor involved too. So even if her cycles are longer than 35 days, there can still be something going on with the male partner. And so all of this gets combined in that 13 months. And right away, we say, well, let's just try some Clomid, because that can be used if there's an ovulation problem. It can also be used if we don't know what's going on. What we know about Clomid, and this is a pill that women use to augment the hormones that get ovulation going at the beginning of the cycle. So what we know about Clomid is that by the 3rd cycle, we have achieved the most pregnancies we're going to achieve with Clomid. Beyond the 6th cycle, there's really no point to doing it any longer. And so many gynecologists and physicians would take you to the 3rd month of Clomid and start saying, at this point, we should start talking about going to the reproductive endocrinology clinic. You should go see the infertility specialist. Which at this point in medicine, when you go there, you may have a couple more labs done. In all likelihood, the recommendation would be for intrauterine insemination. So taking a semen analysis, and outside of the sexual union, in the clinic, like a woman's going to get a pap smear, a tiny catheter is threaded through her cervix and puts the sperm into her uterus. So this doesn't fit with how the Catholic Church sees sex. Sex is supposed to be about bonding. It's supposed to be within that marital intimacy. And so we struggle a little bit with the idea of IUI for that reason. The other option is going to be some form of IVF, or in vitro fertilization, where the semen is collected separate from the marital act, and then the woman's eggs are harvested out of her body, and the two are put together in the lab. Those embryos then that are formed are often tested to figure out which ones are most likely to survive, and those are the ones, and most likely not to have a genetic abnormality, and those are the ones that get implanted. Those that are less likely to survive, the couple is left with a decision about what to do with them. They're either frozen for future use, or often they are discarded. And that can cause some difficulty further on down the road. We tend to think that we can get ourselves pregnant whenever we want to. But at the age of 40, going through one single IVF procedure, which will cost more than $10,000, is not super likely to get you pregnant. The statistics on that vary each year. I would suggest that if anybody has any question or concern about those numbers, feel free to look at the CDC website, or even just Google what are the common success rates of IVF in my area. If we look at what does a restorative reproductive physician do for this couple, if the couple has been charting with their NFP, and they've been having regular ovulatory cycles less than 35 days, and it's been 6 months, then we can actually jump in and start looking a little bit deeper into why the infertility is occurring. So we don't require an entire year. We would look at the entire hormone panel of estrogen and progesterone. I would look at insulin and glucose, and again, the adrenal gland hormones. I would be looking at how the thyroid is functioning, how the pituitary gland is functioning for that woman. I would make recommendation for a male exam, not just looking at the semen and the quality and the number of the sperm, but actually doing a physical exam and an exam of his hormone levels, so that we are taking account of both partners and that we're looking at the whole person and the whole couple, and then trying to achieve pregnancy in a healthy manner. So how do we collect a semen analysis in a way that would be consistent with church teaching? St. Paul VI Institute has collection kits that are available, which are essentially a condom that's perforated. And so the semen gets collected during sex, and then it needs to be brought to a lab immediately. But there's no masturbation, there's no pornography, there's nothing that makes a couple uncomfortable with the situation, and you can still achieve pregnancy with that perforated condom. So it still allows that unitive and procreative aspect that's so important for sexual intimacy. So ultimately, a restorative reproductive approach is going to look at not just the ovulatory cycle, but then it's going to look at both couples. It's going to look at the whole functioning of the woman's body. And then we do use medications like Clomid and Letrozole. We use other medications to treat if there is something like a luteal phase deficiency, where after ovulation there isn't enough hormone to maintain a pregnancy to get to a point of a positive pregnancy test. So there's multiple techniques that we can use. And again, there is data as well that is blossoming and burgeoning, but you can do a quick review of the literature and a quick Google search to just see what are the statistics on restorative reproductive medicine and success rates that way.
What encouragement would you give to a couple that is trying to discern whether or not to use NFP within their marriage?
So I think there's a lot of barriers, so to speak, that are put in front of us when we start looking at this option as we're moving forward, especially if you didn't grow up in a family where this was talked about or used, or if this is brand new to you, or if there's medical concerns. I would highly recommend working with a teacher, finding a healthcare provider who's going to be very supportive of you. One of the things that's pretty amazing to me is how, as we grow in our knowledge and understanding of church teaching, again, I'm a convert, so I'm still learning. I think we all are, is that anything that I know about science is really not conflicting with what church teaching is. And what the church is teaching us here about our bodies being good, that a knowledge of our bodies is good, and that we need to honor our bodies because we are an integrated whole of body, mind, and spirit, reflecting the image of God Himself as a relationship. All of that is going to feed back as you pursue this in a really positive light. I think of Mary, when Mary and Joseph brought Jesus into the temple for the presentation, and she handed her baby to Simeon. Mary had no idea what their lives would be like with Jesus. She just said yes, and she handed this baby over, and Simeon basically told her, it's going to be super hard. You're going to have a stake in your heart. And I can't imagine. We look at NFP and we think, oh my gosh, it's going to be so hard, and we have to take that step forward in faith. If we take that step forward in faith, we're not alone. The church is doing it with us, with the teachers, with the healthcare providers that are choosing to do it, with your priest, and with other couples in the church that are making these choices. Just like Mary, who went before us, She was given the grace to stand at the foot of the cross and see Jesus die and know that God had a plan, and then to be there at the resurrection and to be there in the upper room with the apostles as they waited for the Holy Spirit, saying, He's coming, He's got something for us. We can look to Mary in this. We can look to Joseph standing at our side through this. God will give us the grace in our marriages. He will give us the supports that we need. And it's just a beautiful testament to what He really desires for us is joy.
Thank you so much, Dr. Fisher, for being here today with us. It has been so wonderful to learn from your expertise.
Oh, it's my pleasure. Thank you.